Thank you, everyone, for that kind introduction. Dr. Keyur Dave has already spoken about vitamin D. As my consultants used to say, my endocrinologists during our MD times, every decade seems to have a vitamin which is in vogue. It seems to be vitamin C in the last decade. There are a lot of studies have come up. Vitamin C seemed to have existed before that when we talk about evidences, but COVID has brought it back. It's back in limelight. So just a minute. Sorry, yeah. So vitamin deficiency diseases used to be enormous burden of suffering worldwide, but slowly we discovered each vitamin, and replacing those vitamins have reduced the particular deficient diseases like vitamin D deficiencies and vitamin C deficiency, which is scurvy, to minimal number of people. Now we see these deficiencies only in small number of people who primarily have unbalanced diets or malabsorption syndromes or abnormal losses, which is important for us because our dialysis patients fall in that group, or uncommon genetic defects. In 1990, it was widely believed that if you supplement vitamin, it might even cure cancer or now even cardiovascular diseases. But sadly, all the RCTs and meta-analysis that have happened subsequently have been quite disappointing. However, also they're easily available as supplements, and pharmacy in India is not very difficult. I mean, we can easily buy supplements off the counter, and people tend to self-dose. Higher doses of these vitamins actually can lead to harm. So we'll see more about that. Ascorbic acid, this is the most famous study which happened in 1975, and the most commonly used indication for this is actually common cold. But if you actually see the study, even in this, there was very little or marginal benefit that ascorbic acid actually gave to patients with common cold. So what does vitamin C do in our body? Vitamin C is very important for a number of processes, especially in your immunity-related processes. Maybe that's why it became so famous during COVID. Firstly, it helps with collagen formation, which is going to lead to better wound healing and lesser bleeding. It's an immunomodulator as well as an anti-inflammatory drug. It decreases your hypoxia-inducible factor, decreases DNA methylation, histone methylation. All of these are involved during the process of inflammation, oxidative stress. It also increases your carnitine, catecholamines, and other hormones. All of them are involved during sepsis and inflammation. So vitamin C deficiency is actually more common than we think. There was a study which was done in India in 2011, which showed that an alarming number of 73.9% people from North and 45% people from South were actually deficient in vitamin C. So why does vitamin C deficiency happen? Normally, body can store vitamin C for 3 to 4 years, but especially our CKD patients who have poor intake because of appetite, anorexia, altered taste, they have huge dietary restrictions, specifically citrus fruits and other kind of fruits are restricted in general. There is loss of vitamin C during dialysis. 50% of vitamin C levels, there's a decrease of 50% of vitamin C level with every dialysis session. Uremia alters its metabolic pathways, and polypharmacy, especially your antacids, can lead to interference with gut absorption. So let's look at the good and not so good. This is the Kedoke Guideline, which recently came out in 2020. What it says about vitamin C is that in adults with CKD 1 to 5 or post-transplantation who are at risk of vitamin C deficiency, it is reasonable to consider supplementation to meet the recommended intake of 90 mg per day for men and 75 mg for women. It also analyzed a number of studies which has been done around vitamin C, especially in your dialysis and other CKD patients. What it found was, yes, vitamin C is deficient in our patients. About 40% patients of CKD are deficient. But the studies, which were 5 RCTs and a few case control studies, they did not show any difference in quality of life, mortality, hospitalization in dialysis patients when vitamin C supplementation was given blindly. These studies did not measure the baseline vitamin C level. They were just given in fixed doses like 500 mg after every dialysis session or 250 mg, and they found supplementations did not actually improve the quality of life. Other things that vitamin C it was studied for was the nutritional status. It showed that your pre-albumin and your albumin levels did not change. It's commonly and famously known as an antioxidant and is used in non-inflammatory states. It did not decrease the CRP levels either. However, it was also noted that when you give it at high doses, like 200 or 250 mg or more, 3 times weekly, that is in dialysis patients, there is an accumulation of oxalate and other toxic metabolites, which can lead to potential toxicity. The one part where vitamin C is commonly associated is its use in anemia and CKD. This part was not covered in Kedoke. I have individually analyzed this. What vitamin C does is that it's basically a reducing agent. So it decreases your ferric form to a Fe2+ form, and it improves the mobilization of iron from the stores into the blood, where it can then be used for hemoglobin formation. So it is useful in states of wherein we have high ferritin levels. So there's increased tissue stores of iron in the body, but there's a decreased utilization. So it can be used sometimes as an adjunct to EPO or iron therapy. And like we've already discussed, vitamin C deficiency is common in our patients. So let's look at some studies. Does it really help? These studies all came out in early 2000s to 2015. This was one of the first studies. It compared giving vitamin C 3 times a week to patients, and they were analyzed against the placebo group at the end of 6 months. And what they found was that patients who have high ferritin levels at baseline, if you gave them vitamin C 500 mg 3 times a week, it led to a significant decrease in your EPO dose requirement and improvement in your TSATs. And this was specifically for patients with high ferritin level. This was another study. Patients who had moderate iron stores, in the sense they were normoferritinemic, but their stores were between 100 to 500 microgram per liter. It was seen that even in these patients, if you gave vitamin C supplementation, these were all IV vitamin C, there was a significant improvement in the iron profile and decrease in ferritin levels. So furthering these, people try to even compare oral vitamin C instead of IV vitamin C. And however, this was one small study. It was done only on about 30 patients. What they found was that oral and IV both don't work in improving your iron profile. And in fact, there is an accumulation of oxalate in blood. However, in the 3 months of follow-up in this study, there was no toxicity because of oxalate, which is basically your cardiac toxicity or stone formation. But this is only a 3-month follow-up and again, a small study. So the problem with vitamin C is that most of the studies are extremely small. The RCTs have a sample size of 30 to 60 or maximum 100 patients, and they all have mixed results. So the cat is still out of the bag for this particular indication. We might be able to use it in patients who have very high EPO requirements, very high ferritin levels, can't give anything else. But there are newer therapies now coming in. This is just a cheaper modality which might be used in some settings. The another thing that vitamin C, like we spoke about COVID, there are a lot of trials of vitamin C, a lot of interest of vitamin C around sepsis. So this is one of the largest studies which was published recently in sepsis. This is sepsis with patients and in patients of sepsis with ARDS. This was published recently in 2020 in Nutrients. Ironically, this was actually a negative study, the Citrus ALI study. They had some 43 outcome parameters, of which SOFA score was the main parameter. And grossly, if you use high dose vitamin C, that is at 50 mg per kg, the SOFA scores didn't improve much. But there was a post hoc analysis, and in which they analyzed that of the 43, the 4 most common indicators, that is your ICU free days, your hospital free days, your mortality, and your ventilator free days. Among these three of them, it was significantly, 3 of the parameters significantly improved actually with vitamin C administration. There was actually an 81% decrease in the mortality, which is a handsome decrease. So there might be a lot of, because we are commonly associated with sepsis, as AKI occurs in 50% patients, RRT is needed in 20%, there might be a lot of vitamin C, which is now going to be used in the future in ICU, especially in septic patients. So we need to know what is the metabolism of vitamin C. Like I spoke about, in single intermittent dialysis session, it reduces by 50%. The rate of reduction is actually even higher when we are talking about CRRT, because there is consumption-related substantial oxidative stress. because of the extracorporeal circuit, which can lead to more consumption of vitamin C and lesser plasma levels. So a supplementation of as high as 2 to 6 grams per day might be required in patients who are septic and or on CRRT. The other model where vitamin C has been studied a lot is drug-induced AKI. This primarily came from animal studies, which show that oxidative damage and apoptotic injury is the key underlying mechanism for acute tubular necrosis. These were the initial few rat models and rat studies where they saw that if you gave vitamin C in patients along with cisplatin and colistin, which are known and commonly used nephrotoxic drugs, actually your rate of ATN. Actually, they did a biopsy study of these rats later on, and they thought that the ATN was much lesser if you gave vitamin C along with these drugs. But did it translate clinically? This is one of the only few positive study actually, which showed that colistin, when used for acute kidney, colistin is associated with acute kidney injury. In fact, it's associated in as high as 44% patients who have received it for sepsis. And if you give ascorbic acid simultaneously along with colistin, it might actually reduce your chances of AKI. The p-value was less than 0.05, as you can see. But other studies did not support it. Again, like I've said, most of the studies on ascorbic acid are small size studies. This is one study where the sample size was only 30 patients and they used urinary NGAL as a method for detecting AKI. And what they found was that there was no nephroprotective effect. So most of the studies, in fact, actually, apart from the one I've spoken about earlier, have been negative in drug-induced AKIs. Let's get to the ugly part. So what are the potential side effects when we are giving vitamin C? Everyone thinks it's a water-soluble vitamin. You give it in high doses, it comes out of the kidney. That is not true for our patients because, again, it is metabolized in the body and it forms oxalic acid. So kidney stones is a real risk factor with use of high vitamin C doses. In fact, given at very high doses, sometimes it can act as a pro-oxidant and can worsen the oxidative stress. It is a reducing agent. It can lead to hemolysis in G6PD patients, and it can also lead to incorrect glucose readings from fingerstick glucose meters. Secondary oxalosis is a real risk factor with this, especially in patients who have a GFR of less than 30. Normal vitamin C ascorbic acid levels of more than 100 micromole in blood is what is associated with secondary oxalosis. Lesser levels are actually needed for erythropoiesis and wound healing and for the deficiency improving effects of it. So going above a certain level and overdosing vitamin C actually can lead to side effects. Maintaining it in the median level of 30 to 70 will give you all the benefits. Hemodialysis, when patients are on hemodialysis, and especially if high flux dialyzers are used, it actually decreases the plasma oxalate levels by 71%. And it also reduces your vitamin C levels. So they are dialyzable. This is a recent study which has come out in JASN. In all the previous studies which did monitor, and even in Kedoke, it has been mentioned that oxalate levels did increase, but whether it translated to a clinically significant mortality, we didn't know. But this has now been proven. JASN recently published an article which showed that in dialysis patients, if you have increased oxalic acid levels, then this actually leads to higher mortality and higher level of cardiac deaths. Oxalate stones, we've already spoken about how vitamin C can lead to oxalic acid. Because of time constraint, I'm just going to skip through this really fast. This was a study which actually showed that the vitamin C supplementation is a risk factor mainly for males. This is 11-year follow-up, and this is a very large study of 45,000 men which were done. And vitamin C supplementation at more than 1 gram per day actually leads to increased chances of calcium oxalate stones in males. So the take-home message is that CKD patients are at high risk of vitamin C deficiency, especially a dialysis patient. Initiation and cessation of vitamin C supplementation, as well as supplementing dosage, should take into account the individual's nutritional status, dietary intake, comorbid conditions, and dialysis modality. Malabsorption or disease of an inflammatory nature, patients who have these are more prone. So yes, please go ahead and supplement them. It might improve erythropoiesis, but always make sure that you look out for oxalate toxicity, especially if you're supplementing at high levels of more than 500 mg per day. There is an emerging role in sepsis. It's an antioxidant, and lipid profile should be monitored in these patients. And the role in drug-induced AKI is not yet established. Thank you.